Good morning, everybody. Thanks for this kind invitation. It's my great honor for being here in Egypt. In the last 10 years, I dedicate myself to expanding the indication of therapeutic endoscopy in children. And this is one of the examples of the recent advancement we reached. This is my conflict of interest. And the pediatric trauma is about the 10% of blunt trauma, including the duodenal, and is classically caused by the buccal handlebar or the safety belt. We have two or three published series, one with 31 patients. The mean age was 9. And the second series was quite bigger, was 107 patients with median age of 8.2. So the management of the pancreatic trauma is based on the AST-CT grading scale, where the lowest dangerous were treated with a conservative treatment, like 1 and 2 grade. The intermediate lesions are generally treated with interventional radiology or endoscopy, and the highest grade laceration is generally a surgical indication. The criteria, the main criteria for the management is the duct disruption. And when the duct disruption is confirmed, suspected, or indeterminate, the endoscopy can play a role. When comparing imaging modalities, we know that MRCP, when available, it's more has a major sensitivity rather than CT scan in the confirmation of disruption, and also to confirm the other complication. But for the duct disruption, the most reliable tool is the ERCP, is a prompt ERCP. Does ERCP modify the outcome and the management? Yes, for the evaluation on the duct integrity, for the management of strictures, and for the control of fistula. Is it worth to propose an ERCP for a high-grade lesion for type grade 4 or 5? You can attempt this in the better if before 48 hours. If you demonstrate a complete transection and the patient is hemodynamically stable, and if you have an indeterminate duct rupture. But the problem is the availability of inadequate expertise. Which are the main options in the management based on ERCP? You can do the contrast, you can inject the contrast and perform sphincterotomy alone if you don't demonstrate a leak. Sorry. If you can pass if you can cannulate and you can confirm that there is a communicating fluid collection with the Würzung, but you have difficulties to pass the guide wire in the tail of the pancreas, you can perform a transpancreatic drainage with double pigtail. But if you can pass the wire and reach the tail, you can put a stent across the length of the injury. The old school say that for pediatric fluid collection, the management is very often conservative. Only 1/3 of patients require drainage, and only 26% of this third received cystogastrostomy. The rest of the patient at that time was treated with the radiology. But this data came from last decade, where the US was not mature, especially in the US, in the pediatric field. And it was a mixed data between percutaneous and plastic stent management, not based on US drainage. And also the time for ERCP was a little bit late. So there is no available data at the moment for LAMS era. What we are trying to do to overcome this training limitation is the simulation. It was historically a tool very important for pediatrics to teach, to learn from adults. But there is a shift now from the animal-based model, which are costly and there are hygienical and ethical constraints, to plastic simulator that offer the possible to reuse the tools and makes like a gamification. So this is why in our hospital we developed this 3D printed simulator, which allows the possibility to perform virtually any therapeutic task, and you will have the chance to try this tomorrow. And for pancreatic fluid collection, as in this case, we will perform the pigtail stent placement. So you can dilatate, you can use cutting, so the current, and then you can enlarge the hole, and you can put the pigtail as in the normal life. So what is the management we are establishing the last 5 or 6 years? It's about, we have an experience of 3-4 patients per year, which has this kind of trauma and are referred to our tertiary center. And generally they present a pancreatic transection with the birthing rupture, and this management is indicated for infective or obstructing fluid collection. So we generally perform during the same procedure an ERCP with sphincterotomy, with or without stenting according to the type of the lesion and the possibility to advance the wire. We can perform a drainage if indicated with LAMS or double pigtail according to the position. And we always place a nose jejunal to improve peristaltic vacuum and to favor early refeeding. Which problem we encountered during this management? This patient was a 9-year girl with a bite trauma, and she had a grade 2 laceration. And she presented an obstructing PFC, where we put immediately 2 pigtails. And 1 week after, we performed the ERCP with a major papilla sphincterotomy, but we could not dominate the pancreatic tail, and we also experienced a pigtail dislodgement. So 3 weeks later, the patient was stable but developed a pseudocyst, a voluminous pseudocyst. So we put 10-15 lumps with a complete resolution. And finally, after 3 months, we did the MRCP and we understood that it was a division. But even though without a proper drainage, the patient improved just with the lumps. And this is another case, recent, a patient of 12 years girl with a car accident. And she had a complete pancreatic transection, and she received an angiography for a pancreatico-duodenal branch embolization. And 3 days after the trauma, we did the all-in-one procedure. So with the sphincterotomy, with transpancreatic pigtail because we could not reach the pancreatic tail, with the lumps and the nose-jejunal tube. But unfortunately, the CT scan showed that the 2 stumps of the pancreas were very far. So we were worried about her pancreatic function. So we put on a follow-up. And at the moment, she is now under good clinical condition and the pancreatic function is very good. But we will see if the birthing gastrum will be necessary in the future. So to conclude, the pancreatic trauma requires a prompt endoscopic management with a good outcome and a minimal invasiveness. ERCP and US are complementary in the decompression of the duct and the management of fluid collection. And simulation training is crucial to ensure high quality procedure in low volume setting. Thank you.